Hi, my name is Connie Koklanis and you're watching the video Orbital Injuries Management. In this video, we will be discussing both non-surgical and surgical management options for a patient who presents with an orbital injury. So when a patient presents with an orbital injury and specifically with a blowout fracture, we want to assess this patient extremely regularly, and we're discussing seeing them every 3 or 4 days from the time of the accident. And the reason we're doing this is we're trying to determine whether this patient needs early surgery. We'll come to this in a moment. But we're looking, with this regular assessment, looking to see whether there's any improvements in ocular movements and whether there's any signs or indicators for surgery, such as the development of an ophthalmos. So as you see this patient regularly, some of the investigations that are critical to map improvements of ocular movements or to map change is visual acuity is a standard, but looking at ocular movements, a Hess chart in the field of BSV will give you an indication of what's happening with the diplopia, what's happening with the ocular movements. Should any eye movement limitations be due to soft tissue injury, this should subside or spontaneously resolve with the recovery of the swelling. Where a patient has a complaint of diplopia and you need to manage this, we would do this with traditional methods that you already know, the prisms, occlusion, or the utilisation of an abnormal head posture. So assist your patient as best you can. One of the troubles will be a patient with reversal of height. They're very difficult to manage with prisms, clearly, because what will happen is that the prism will be either base up or base down if you have a vertical deviation, and will actually make the situation worse in the gaze where you have reversal of the vertical deviation in this example. Okay, so what are the indications for surgery? With blowout fractures, unlike neurogenic pauses, we have this window of opportunity where some patients must be operated on early. And the indicators for surgery early are a significant degree of an ophthalmos, and that can range from about 2 to 3 millimetres as being the indicator for surgery. If you have significant bone fractures, surgery should occur early. If there's entrapped muscle, surgery should occur early. And then if, say for instance, there's still continued diplopia and there's the possibility of restricted eye movements after 2 weeks, then again, looking at early surgery. And so obviously the positive force duction test with that will be an indicator for surgery as well. So when should surgery be performed? I've mentioned early surgery. What's early surgery? Early surgery is performing surgery within the first few weeks of trauma or within the 14 to 21 days of trauma. If you wait for 14 to 21 days to operate or to go into surgery, your findings are a little bit more accurate in the sense that swelling subsided and the force duction test, for instance, is more reliable, etc. Going under 7 days can be quite controversial and could lead to issues if there is a misdiagnosis at that point. In children where you have a white eye fracture or a trapdoor fracture, this is usually an urgent requirement for surgery. In terms of early surgery, the reason we do early surgery is to repair significant fractures or to remove entrapped muscle. And it's important that that is done early, because if left too long, fibrosis can occur, and it can actually result in more permanent damage to the muscles and nerves. We're not actually talking about doing early surgery on the extraocular muscles, so the traditional things we've learnt about so far around recessions or resections of an extraocular muscle. That can wait. All we're talking about in relation to early surgery is specifically repair of the fracture or free entrapped tissue or muscle. So what are the aims of surgery, whether it is the early surgery or also later surgery on extraocular muscles? Well, those early surgeries, we're going to try and close any bony defects, free entrapped muscles or tissue, and try to cosmetically assume a normal anatomical arrangements of the orbital contents. We also want to expand the area of BSV and resolve diplopia. Now, when you free entrapped muscles, there may be an expansion of BSV, etc. But if over time there is no further improvement or there's little improvement, and in 6 months' time the patient still has issues, then extraocular muscle surgery would be required at this point. And the purpose for this will be to expand the area of BSV and resolve the diplopia in this instance. Just a note also that repair of blowout fractures usually requires a multidisciplinary team, and specifically the maxillofacial surgeons and the ophthalmologists work together. In terms of the type of procedures, I've already mentioned that one of the things that can be done is strengthening the bone or repairing the fracture, and also freeing that entrapped muscle. So these two procedures are done early, within the first few weeks post-injury. And in relation to strengthening the bone, the most commonly used material is titanium sheets. And we can see here an example of a patient who's had repair of their fractures. As I mentioned earlier, extraocular muscle surgery, so if you're looking at strengthening or weakening an extraocular muscle, this can wait till later and it can be delayed. It doesn't have to occur in those first few weeks. So you can wait around 6 months for extraocular muscle surgery. And if a patient also has a neurogenic palsy from trauma, then this you'll treat as per usual, like a neurogenic palsy, so you would wait that minimum of 6 months. We're not going to go through all the various procedures that can be performed on the various types of blowout fractures, but there are a couple of general principles that can be utilised. So one, often the overacting muscles of the unaffected eye are weakened. If there is an associated palsy, then you could strengthen that palsied muscle if it's partial in particular. And also you could look at Farden procedures. So where you have a patient who you don't want to have an impact in primary position, the eyes are relatively straight, and you have a limitation in a position of gaze, you can look at matching the deficit using a Farden procedure, so that you can limit the eye movement of the contralateral eye in the same direction as the other limitation. In summary, these patients, when they present, need regular monitoring at the beginning. And so you're looking at reviewing them every 3 days to look for improvement in the double vision, in the ocular movements. You're looking for signs that are indicators for surgery, such as anophthalmos, etc. Surgery for large fractures and entrapped muscles or anophthalmos need to be performed early. Okay, and then lastly, you consider the extraocular muscle surgery, which can occur later down the track after about 6 months, and again, wait for stability of ocular movements, and at that point, you can operate on the extraocular muscles in terms of strengthening or weakening procedures as required. Okay, that brings us to the conclusion of this video. Thank you for watching.